Hey, thank you. And leaving San Diego in June gloom, it feels like home here today. So, my talk was fusion versus arthroplasty, and I don't necessarily believe it's one versus the other. I do believe that that fusion still play an important role, and we shouldn't forget about it. In the treatment algorithm of degenerative disc disease, and this is what we're talking about when we're talking about fusion, I'm going to limit my talk to degenerative disc disease and as an indication for surgery. And it's not one against the other, but at the very end is a fusion and or total disc replacement. So as I said before, arthrodesis, you don't throw that away. It still has a lot of support for instability, for revision surgery, or a progressive slip. Not in the adult, but in the younger individuals when you're dealing with L5-S1 spondylolisthesis. So it definitely still has a place in our armamentarium. But through those studies, and through those treatment modalities, we learned about the detrimental effects of fusion. First of all, you need bone graft. And yes, there are alternatives, and Ganesh just gave a great talk on alternatives. I do not harvest the iliac crest because of that, and haven't done so in a long time. There's a risk, however, of pseudarthrosis. If you do not fix that motion segment in the right sagittal alignment, it'll stay in that fixed sagittal alignment, and that could be a problem in the long run. And of course, adjacent segment disease, and something to this day is perplexing to me. To me, it's not just about increasing the pressure at the adjacent level, it's also more complicated than that and involves biologic factors and others that we just don't know yet. But having said that, we know that there seems to be a correlation between a fusion and adjacent segment pathology or degeneration. It's radiographic and also clinically relevant and presenting differently, either through radiculopathy and spinal stenosis, instability and back pain, and spinal pelvic mismatches. So all these are different presentations that one can see. And there are other papers that also support that as well, where you see a higher incidence of radiographic adjacent segment disease, and then clinically relevant tends to be a little bit lower than that. And then, again, a meta-analysis done by Paul Park and his co-authors, again, verified this, and you could see that the incidence radiographically tends to be higher than those who were clinically symptomatic. Park took it one further step, and he identified certain risk factors to adjacent segment disease, and that being pedicle screws, facet joint violation, a sagittal malalignment, and fusion length. So all those precursors can accelerate adjacent segment disease. Punjabi looked at it interestingly from a different perspective. He said, hey, let's not fuse at a level. Let's put in a motion segment with total disc replacement and compare it to fusion, and looked at a cadaveric model. And what he found was those cadavers that had total disc replacement had basically a similar adjacent segment values as the intact spine, and greater stress on the adjacent level was found with fusion, right? And in general, that's what he concluded at all spinal levels. So that kind of led to dynamic stabilization. Can they theoretically give us predictably diminish stresses to the adjacent level, and therefore longevity with time? And they started in the back, or similarly to the front. You found all these posterior dynamic systems, but those posterior dynamic systems went raced through the Scott's parabola, and pretty much, although promising in the beginning, became a standard treatment. And then you saw some damaging reports, and they've fallen pretty much, in the US at least, into disuse. What has survived dynamically, though, at least from the low back, and you hear Michael Jansen in a moment speak about cervical spine, and what has survived are the total disc replacements. And what's really neat about these is that as we're seeing more and more time from the date of implant, these studies show that these things really do really well, really, really well. And that's where they separate themselves from fusion. I'm not here promoting total disc replacement, but I've watched these carefully, and the outcomes just seem to get better compared to fusions as time goes on. So I'm not going to say the best fusion data comes from these IDE trials, right? So I'm not going to separate out the studies which are largely retrospective or level 2 and 3 at best for fusion studies because the IDE trials gave us the best data we had as far as fusions are concerned. Here's a short list of IDE trials that were performed in the US. Here is the inclusion criteria. And let me just say that this, and I do a lot more neck disc replacement than I do lumbar, just because the indications for cervical are the same as an ACDF. For lumbar, it's back pain, and I tend to do less fusion surgery and total disc replacement for back pain. But having said that, if you follow this IDE criteria, that's where you see the best success up until this date. There are some exceptions, and with time, we found that the inclusion criteria can be expanded where we excluded them in the very beginning, and this we learned with the IDE trials. So looking at the literature review, the seminal papers, the IDE trials, and you could see here the initial ones with the Charité and with the ProDisc, they showed some very promising data. In the first couple of years, they were no different at all than a fusion. So you got somewhere anywhere from 75 to 80% good to excellent results, and the fusion patients did as well, or the total disc patients did as well as the fusion patients, and both were found to be safe and effective. The Maverick, which had a patent issue, but their data did come up, but we do have several years on that. At 24 months of follow-up, both groups showed improved significantly, right? But what happened was later on, the total disc compared to ALIF on the ODI, the SF36 and back pain scores were better for the total disc group compared to the fusion group. And those patients who would have surgery again basically fell into the total disc replacement group compared to the fusion group. So the overall success seemed to be better for the total disc replacement group compared to the ALIF group. And that was for the Maverick. So again, things were seen, at least early on, to be just as good, maybe a little bit better. Kineflex very similarly showed us, again, what the Maverick showed us, the ProDisc and the Charité. The cool thing about the Kineflex, though, is that it was the first of its kind of a disc-to-disc comparison as opposed to a disc-to-fusion. And what it showed was it showed that both seemed to have similar results, and there were no significant differences between the Charité and the Kineflex, at least early on. But what the Kineflex work did show us was that if you preserved at least 4 degrees or more of motion, you tended to do better than those who had less motion. So preserving motion was important. So what happened at 5 years? Now we're getting a little further along, and this is where total disc tends to separate itself from fusion. And what you see is as long as the range of motion was preserved, right, the TDR had a significantly greater return to work and fewer patients on long-term disability compared to the fusion group. So the Charité even Charité, which is rarely used today, or at least in the US, it's off the market because of other reasons, but those that did worked super well. And this is the ProDisc L 5-year Jack Ziegler's study, and TBI really should be given a lot of credit for a lot of the papers in the US that has come out in favor of or comparing total disc replacement to fusion, and they should be credited with that. So as long as the range of motion was preserved, both groups remained significantly improved, and there were no significant changes from the 2-year data. Rick Delamarter looked at 2-level 5-year data for total disc replacement using ProDisc, and what he found was that 2 and 5 years, TDR had significantly greater satisfaction rates. And guess what? In the cervical spine, and not to take away Michael's thunder, somehow the 2-level disc replacements in the neck had better outcomes than single-level TDR in the cervical spine compared to ACDF. So it's pretty impressive data. The Maverick data, 5 years, again, the superiority of the TDR compared with infuse-based fusions. And guess what? They had a better than 90% fusion rates with infuse, and the TDR was still superior, at least at 5 years. And then looking at the 10-year data with Charité, look at this, the results still were quite excellent. More than 90% who did follow up had good to excellent outcomes, and more than 90% returned to work, and range of motion was maintained in 95% of the patients. So again, range of motion preservation is important to outcome. And again, more than 10-year follow-up, you can look at these, and again, the same similar data. Complications using the total disc replacement, if properly done, is pretty rare, less than 0.5%. Here are the reasons, and I think these are all surgeon errors. Fractures, you've got to be very careful, especially with those keel-based total disc replacements. And if you've got a patient with osteopenia or osteoporosis, this can be a problem. Subsidence, I think you avoid that by making sure you don't get into the bony end plate, and then vascular injuries from the approach, which is rare. If you look at the revision data of fusion versus total disc replacement, you could see that the revision for total disc replacement, about half of those with a fusion, and the reason for revision for fusion is adjacent segment disease. Preservation of motion, I talked about it, and we'll revisit it here. So normally each lumbar level has about 14 degrees of motion, but if you look at the series of total disc replacement, they preserve about half at best. Rick Delamarter showed, and this is where things shifted, right, from this paper, is that at L4-5, you tended to preserve the best range of motion at that level. And what he found was that at L5-S1, you really didn't preserve that much motion, especially for those deep-seated L5-S1. And so the question was here, was there really a benefit to doing a total disc replacement at L5-S1? And this is where things flipped, and now we came into hybrid models of an L5-S1 fusion and a total disc replacement at L4-5. And what really came out of this is if you do flexion extension views preoperatively, and if you have less than 5 degrees of motion at the L5-S1 level on flexion extension views, you should probably just do a fusion, because preserving motion there is not going to happen, so it's a useless operation. What about adjacent segment disease? This is why we're supposedly doing this operation, and really the literature is all over the place for this, and we really don't have a good idea, handle on this. And as I said, it's just more than just preserving motion or fusion at the level below. I think there are biologic factors that we are not aware of. There are genetic factors that we are unaware of. And I think that the data reflects this. That is why it is all over the place. But however, if you look at what was gleaned from the IDE trials and looking at the total disc replacement trials, you could see that from comparing the fusion data to the total disc replacement data, that adjacent segment was lower in disease, was lower in the total disc replacement group, and this carried on with time. Ziegler's study also looked at this, and they had independent radiologists looking at it. And what they found was there was no change in ASD in the groups, in the total disc replacement group compared to the fusion group, and that no ASD, if there was no ASD pre-op at 5 years, ASD was found in only almost 7% of the TDR group compared to almost 25% of the fusion group. And then the reoperation rate, however, was similar, right? It was not significantly different, which goes again to say that you have to look, when you look at the studies, make sure you see radiographically significant adjacent segment disease and then clinically significant that requires an operation. Pretty different. The cost, at least up front, seems to be similar to a fusion compared to total disc replacement. But as you could see with time, total disc replacement seems to be better, and the reoperation rate is lower compared to the fusion group. So long-term study, it seems that the cost of total disc replacement is better than fusion. So I think that also the total disc replacement is just one implant and just put it in, and that's great. You can predict the cost of the operation, whereas a fusion, if you put in your interbody and then your graft extender and then your pedicle screws and then your plate, that can vary the cost. And you'd think to insurers this would be valuable. Just a quick word about the evolution of indications. What time has taught us is that now we can, in minor facet changes, we can still do a total disc replacement. Patient had a previous discectomy, and there are no end plate changes, and there's no instability, you could probably still do a total disc replacement. And then age greater than 60 is a relative contraindication if you carefully select your patients, as was just presented. And then finally, you have smokers, you have to be aware of possible osteopenia. This is one of the landmark articles that shifted that indication, Jean-Charles Louek's study that said, look, if you have a facet arthrosis that is a Bogdan grade 1 or 2, it's no never mind, and you could go ahead and do your total disc replacement and your outcomes won't change. The negative influence came with grade 3 and grade 4. And then the total disc, the L5S1 disc, again, I just mentioned that. It's unique, and I think if you do your flexion extension views, if you have greater than 5 degrees of motion, I think you could still indicate your patient for total disc. If not, then you should probably look at a fusion. So in summary, there's still today strong data which seems to get better and better as we see the longer term outcomes to support safety and efficacy of total disc replacement. I think the revision rate is low. There are great randomized controlled studies. There's 10-plus year data from Europe and coming out in the States. And the total disc replacement is similar in cost to fusion or less expensive as you go further out, and your revision rate is lower compared to fusion. Thank you.
Thank you, JJ. Fantastic talk. And I didn't know where you're going to go with your analysis, so hearing this from you is really important. 2 quick questions. So spinal alignment, again, one of the huge contributions of the French-speaking surgery community to our understanding of the spine has received such an emphasis. In general, do you think that the spine and the lumbar spine can rebalance itself better if we give it a chance to do a correctly placed arthroplasty versus a fusion or not?
That's a great question, and my experiences come from France and Jean-Charles Louek and Roussely, and I'm going to speak more of that in my next talk on spondylolytic spondylolisthesis and Roussely's and the Spinal Deformity Study Group, their work. But having spent time with Jean-Charles and listening to Jean-Charles over the years in the French, they talk about balance, and their theory makes sense to me, and that if you put in a total disc replacement, the alignment, the sagittal alignment, will find its position using a total disc replacement. So I think strategically you can do that. It makes sense to me, and I think the data from the U.S. and Dr. Dimar can speak about it more. But I think that it makes sense.
Talk to us about.
I have a quick question.
Oh, sorry. Yeah, go ahead, Mike.
This is Mike Jansen. Thanks, JJ. That was outstanding, number one. How about recovery? Because when I do a total disc on a patient, I only restrict them for about 6 weeks. And at 6 weeks, I let them do everything. Ski, mountain bike, do everything. In our fusion patients, it's many months before I think they have a biological support. So I think also I tell my patients if they're looking at these two options, I personally think it's a quicker, faster recovery for these patients after an arthroplasty if they both would be a candidate for both. But I'm curious what your thoughts are.
So it's funny, Mike Jansen is in the same class as Tom Cruise. I mean, they are absolute junkies when it comes to that. So would I do the Mike Jansen activity at 6 weeks? No, because Mike does incredible stuff. And I always worry about him. And when I see him racing and doing things, I tell him, please be careful. So yes, you're absolutely right, Mike. In the neck, as in the low back, I return them to activity a lot sooner than a fusion. And why? Because you're as stable as you're going to be. If you did your implant surgery properly, they're as stable as they're going to be, right? And if you haven't, it's going to fail. So I'm still a little bit nervous about returning them to the Mike Jansen level within a few weeks, but I do let them get back certainly to work and to play a lot sooner than a fusion.
Let me ask you about fusions a little bit. Dr. I want to not mispronounce his name, Farakbash from the University of Tehran asked, we're old enough to have known posterolateral fusions and this abundant, massive bone graft that can be formed there. Was that a result of good technique, or is there something to kind of allowing this kind of a stress concentration of the posterolateral gutter as opposed to the anterior inner body space to mature these profound fusions?
Well, I think I'll speak more about it in my next talk.
Okay.
That's a great question. Ganesh, I think, had a wonderful talk on that. I think that you improve stiffness, if you look at Casey Lee's work, by doing an anterior interbody significantly more than if you do a posterior one. The posterior fusion, even as solid as it is always under tension, and I'm always nervous about it. And that's why I like the interbody technique. And I'll let you know which. I mean, as my next talk comes up, I think if you have a solid fusion in the back, particularly if you're dealing with deformity, I never take out the hardware. I'm just nervous about the tension that you're leaving that fusion under. I think it's a lot.
We'll revisit that again. Thank you for your question, Dr. Farakbash. One more question for you, and that is disc implants, lumbar disc implants, enormous stress risers. Is it more important to have that little bit of mobility to minimize the stress to the next higher level, or would you like to have discs have some squishiness, some give to them?
Geez, I really wish that those posterior dynamic systems would have shown better than they did. Because hypothetically, theoretically, subjectively, yeah, I do believe that it can. A lot plays on our technique. I mean, how do you prevent adjacent segment, adjacent level facet trauma? Just doing your exposure, I think you damage those adjacent levels. As careful as we are, I think we do it. I do believe that that fusion does affect adjacent segment disease, but I think that there's a lot more to it that we don't understand yet, Jens. I think there's a lot more to it. But I wish the posterior dynamic systems had performed better than they did. Yeah.
Great perspectives and more to come. Thank you, JJ.